Hello, my name is Corey Langer. I'm the Director of Thoracic Oncology at the Abramson Cancer Center at the University of Pennsylvania. And it's my privilege today to do an expert wrap-up on the 20th Annual Perspectives in Thoracic Oncology meeting here in New York City. It's my privilege as well to be joined by Beth Eaby-Sandy, who's the first thoracic oncology nurse practitioner in our practice. She's now been joined by 3 other nurse practitioners and 1 PA, at least 4 other individuals who co-collaborate with the physicians in our practice. A lot's been happening in thoracic oncology, particularly over the past 2 years, and I think probably one of the most important game changers is the advent of Immuno Oncology. Just this year, at the beginning of the year, nivolumab in a phase 3 trial compared to standard second-line docetaxel proved superior, much better response rate, major improvement in progression-free survival, and most importantly, nearly a 50% improvement in median survival with a near doubling in 1 and 12-month and 18-month survival. And about 2 months after that, we observed similar data for Nivo in the non-squamous population. P-value wasn't quite so impressive, but still statistically significant advantage compared to docetaxel. Dr. Gajil has reviewed these data today. How has this changed your practice, your collaborative practice with Dr. Evans?
Yeah, you know, it's really offered a new therapy for patients that has less toxicity associated with it. The schedule is fairly convenient for patients, and it's offered them hope, to be frank, a new type of therapy.
So it's pretty much changed your standard. You no longer use docetaxel in second line.
So in the second line setting, I think barring any reasons that they can't get an immunotherapy, we would use one of these drugs that's now approved.
So nivolumab, what about pembrolizumab? Pembro was approved, but with the caveat of a companion diagnostic that stipulates a IHC PDL1 score of at least 50% or higher. Does that pose an impediment? Which is easier to implement?
You know, I think it does. And with nivolumab being approved first, we've gotten a comfort level with administering the drug and its toxicities associated with it. So I think the pembrolizumab use has been limited now because we have another option that doesn't require us to wait for the results or order a companion diagnostic test.
So it's frankly easier to give, or at least easier to order, because it doesn't have the companion diagnostic. There are some interesting nuances. Certainly in the non-squamous population, in the secondary analysis, PDL1 score did make a difference. In the squamous population, the benefits with respect to response rate, progression-free, and overall survival were independent of PDL1 status. But in the non-squamous group, whether we looked at a 1% cutoff or a 5% cutoff or 10% cutoff for PDL1, those with proportional scores above those stipulations had about a 10 or 12-month improvement in median survival, whereas those who were below the cutoffs, there was no advantage versus docetaxel. So does that color the conversation at all? If you knew somebody had PDL1 status, was positive, would you preferentially use nivolumab, or for that matter, if it's above 50%, you knew a priori that existed, would you give pembro in that situation?
Do you mean in the first line setting?
No,
or
second.
in the second line setting?
In the, yeah.
So would I use pembrolizumab as opposed to nivolumab in that setting? I think for right now there's not enough data to support that. I think it would be provocative and something I may think about, and it's approved, so it's something that could be done, but I think that it's not quite strong enough yet.
Certainly we have no head-to-head comparisons,
exactly.
And it's not clear if we ever will, considering the stakes that exist for each of these drugs. But in rapid-fire order, within a 10-month period, 3 new indications. So it's really quite exciting, and it certainly changed the therapeutic landscape in the second-line setting. I want to dial back to the first-line setting. And maybe the third-line setting, the resurrection of angiogenesis inhibition. Bevacizumab, of course, was approved based on ECOG 4599. Dr. Ross did a nice review of those data. It showed a statistically significant, I would still argue clinically meaningful improvement in survival of about 2+ months. At least up to the age of 75, those benefits were clear. Above 75, a little bit shakier. There was a second trial from Japan called Beyond, basically the same study design with Pat Carbo as the platform, showing about a 6-month advantage. A lot of folks aren't terribly aware of that. And now, within the last year and a half, the Revel trial looking at a different angiogenesis inhibitor, in this case ramucirumab, I have to pronounce these things correctly, which targets the receptor as opposed to the ligand, which is the target of bevacizumab. In second line, showing an advantage in combination with docetaxel compared to docetaxel alone. Again, about a 2-month survival advantage. How is this recent accretion of data changed practice, or hasn't it changed practice?
Well, it's tough because with the immunotherapy drugs now, we tend to go to that as a second-line therapy as opposed to the docetaxel and ramucirumab. So that gets pushed back on the back burner a little bit. I do think one of the interesting things about the ramucirumab is that it did not exclude patients with hemoptysis. So for those patients that maybe we would not have used bevacizumab in the first-line setting, that could be a VEGF option for them in later settings. However, again, I think it's been pushed back a little bit due to the advent of the immunotherapies in the second-line setting.
So effectively, docetaxel now is, even though it wasn't really, ramucirumab wasn't tested officially in that setting, it's becoming third-line treatment.
I think it's fair to say that.
And for both adenocarcinoma and for squamous cell. That's the other major distinction from the original ECOG 4599 data, which resulted in bevacizumab's approval. This particular study allowed squamous histology, which wasn't included. So yet another option. And it does make for exciting times. Of course, there's a bit more toxicity. Even in the group where they compared nivolumab to docetaxel, where there was no obvious survival advantage in the low PD-L1 patients who had non-squamous histology, toxicity is much less. And so how do you deal with this toxicity?
So the toxicity of the immunotherapies?
Yes.
In my experience with both nivolumab and pembrolizumab, it's been pretty minimal. Obviously, what I think is important for providers to think about is to know what those toxicities may be if they're going to experience them. Because if they do, they can get bad pretty quickly. So the things like dermatitis, pneumonitis, colitis, if those are immune-mediated toxicities that you may experience. So if they experience them, even at the grade 2 level, you're supposed to hold treatment and initiate steroids at that time. The one other thing I do like to differentiate as well is the difference between diarrhea and colitis. So if they develop some diarrhea, it's okay to use antidiarrheals. But however, if it is truly colitis with bloody or mucus stools, that's when you need to hold therapy and consider the use of steroids.
And steroids are pretty much the, not necessarily the panacea, but the standard therapeutic option for combating the wide range of toxicities that occur with these
But
compounds.
I do want to continue to mention, these were all less than 10% in the nivolumab and pembrolizumab
and
trials.
frankly, far less toxic than docetaxel,
Absolutely.
where the grade 3 rates were 50% or higher. And that doesn't lessen the fact that we're still dealing with that toxicity now in third line with docetaxel and ramucirumab. We do see more neutropenic fever. Tell me, in your practice, do you routinely graft growth factor support with docetaxel?
Yes, when given at the 75 milligrams per meter squared every 3-week dose, I would routinely add growth factor to prevent
pegfilgrastim.
Pegfilgrastim, yes, to prevent the neutropenia.
Have you opted to cut back on the dose from 75 to 60 per meter squared? I know the East Asians have on occasion.
No, I haven't routinely done that unless there's another toxicity that would mandate me doing that.
Which pegfilgrastim wouldn't combat.
Right.
Yeah. So for about 10 to 15% of our patients, molecular therapy, EGFR mutations are present. If we look at the group, female patients, East Asian ethnicity, adenocarcinoma histology, never smokers, the incidence of EGFR mutations is roughly 2/3. We have 3 options now. Erlotinib, which has been our standard go-to option for the past 5 years, at least, in those with EGFR mutation. The last 2 years, afatinib, which recently showed a survival benefit versus either PEM platinum or GEM platinum in DEL 19, so deletion 19 specifically. And now just in the last few months, really since the summer of 2015, the resurrection of gefitinib, which was the first EGFR inhibitor to be approved, lost approval now in the same context in folks with a actionable EGFR mutation. It is now approved. So what's your standard practice? Do you use erlotinib across the board? Have you made the switch and selected patients to afatinib in some cases?
So I think erlotinib is what we've been using for the most part. We have, over the past 6 months, with that deletion 19 overall survival evidence that came out, we have placed some of the deletion 19 patients on afatinib. We use the 40 milligram daily dosing to start. It is a more toxic drug, it appears, from a rash and diarrhea perspective, on paper anyway. I don't know how much that translates into practice. I think as long as you're able to manage the side effects or dose reduce, as was fairly common in the clinical trial with afatinib.
You do see some stomatitis, which you typically don't see all that often with erlotinib or gefitinib. Mm-hmm. How do you manage the rash? What prophylactic measures do you usually institute?
So I'm going to be honest, I don't usually use prophylactic measures. I usually will treat it because I do see that many patients don't have too much of a problem with it. And I don't necessarily want to start them on oral antibiotics or topicals, prior to them experiencing it. And they're not anxious to start, extra medications as well. I think once the rash begins, I follow up with all of the patients in clinic between 10 and 14 days after starting the drug.
So toxicity check early on.
Exactly. That's about the time when you're going to see these toxicities become a problem. At that time, I would probably initiate topicals if it was just a very mild rash, things like a clindamycin gel or topical hydrocortisone cream over the counter is fine, or even a 2% if you need to. If it's a little bit worse than that, I would go right to the oral doxycycline. I think that's a good strategy to prevent rash, especially if the rash is on multiple areas of the body or in the scalp, because topicals won't reach all of those areas necessarily.
And what about later manifestations, the cutaneous toxicity, digital fissuring, paronychia? How do you manage those?
Yeah, so those can be really difficult. The fissuring of hands or heels especially can be an issue. Thick moisturizers, as well as even using things like liquid Band-Aid or super glue to seal up those cracks is actually a good treatment strategy to avoid infection. Paronychias are really difficult on the toes or the fingernails. Preventing those is the best thing. So wearing protective, shoes or wearing protective gloves in the cold, or trying to avoid things that are creating a lot of friction in those areas. I had a woman who used to wear very tight boots on her feet, and then the paronychias would be very bad and difficult to deal with. Culturing them, treating it if it's an infectious etiology, but truthfully, for the most part, it's an inflammation, and sometimes you need to do something like a partial nail avulsion to cut out that area.
It's never really grade 3 or 4, but chronic grade 1 or 2 toxicity is still quite
very annoying for patients.
Yeah. In the last 2 years, we've also seen the manifestation, the advent of second-line, third-generation oral TKIs that maintain activity against the original activating mutation, be it exon 19 or exon 21, but also against T790. About 60% of those who develop acquired resistance will manifest T790 on subsequent tissue biopsies, and for that matter, now liquid biopsies in the blood. 2 separate drugs have been developed, rosaletinib, or the Clovis compound, and more recently, and very recently approved, just in November of 2015, osimertinib, or AZD9291. How has that changed practice for you and Tracy?
Well, I think it's really exciting. We've used these drugs in clinical trials and watched patients have some good responses. It also gives them an option to keep on the molecular targeted pathway after failure of the EGFR inhibitor. So it's really exciting. Again, I think these drugs are pretty well tolerated, considering that the EGFR inhibitors, they may have had a tough time with rash and diarrhea. So they've been really well tolerated.
So rash and diarrhea, rosaletinib actually spares EGFR wild type, so we tend not to see much in the way of rash and diarrhea. In the AZD compound, it's much lower levels of EGFR wild type, so there is some rash and diarrhea, but much less than we've typically seen.
Than what we would
but the rosaletinib compound does have a fair amount of hyperglycemia, which is thought to be due to one of the metabolites that targets IGFR1. So how is that managed?
So yeah, we've dealt with that, of course, in our practices using the drug in clinical trials. For right now, we're trying to avoid the use of any insulin and try to use things like metformin or standard oral anti-hyperglycemics at this time.
And this is symptomatic hyperglycemia. This isn't just a paper toxicity.
No, it certainly can be symptomatic. But I have seen that with the use of metformin, sometimes I've had to escalate the doses, but that it does manage it. So I haven't really had to go to 2 or 3 drugs in patients. So it is manageable.
So the potential advantage, of course, for osimertinib in this setting, with 2 drugs that have ostensibly identical response rates, is the absence of the hyperglycemia, the absence of major QTc prolongation. And rash and diarrhea, of course, we're used to dealing with in the first line, so it's really no great stretch to deal with it in the second line. And of course, this further puts off the need for instituting systemic chemotherapy. There was a trial called the IMPRESS trial that was alluded to during the meeting that looked at gefitinib beyond progression in patients with EGFR mutation who had responded and then developed disease progression, essentially comparing standard chemo, PEM platinum, to PEM platinum plus gefitinib, and failed to show any advantage. Many had speculated or hypothesized that you needed to stay on a TKI indefinitely, that there was still a clone present that would be sensitive. But once chemo is instituted, that assumption falls by the wayside. There was no advantage with respect to response rate or progression-free survival, and in fact, early on, a survival decrement in the group that continued the gefitinib. So once the TKIs are exhausted, what's your standard go-to regimen when in the EGFR mutant who's no longer responding to a TKI?
So normally they are adenocarcinoma patients. So what we've tended to do is we've tended to continue the EGFR inhibitor up until the time they're going to start chemotherapy. And then once they start chemotherapy, we've taken away the EGFR inhibitor. And usually we're going to start with something like pemetrexed with a platinum, with or without bevacizumab, depending on the patient eligibility, because most of them tend to be adenocarcinoma patients already.
And it's safe to say it's usually carboplatin.
Yes.
Almost exclusively
Almost
carboplatin.
exclusively, yes.
Yeah, I have a philosophical distinction here. In the curative setting, where the data really support it, cisplatin is our go-to drug, and certainly in the adjuvant setting and in locally advanced, not exclusively but frequently we'll use cisplatin, but in the incurable setting in patients who are, they may enjoy several years of longevity, but they're not likely to be cured. Carbo is a much safer drug.
Yes, routinely we'll use carboplatin as a backbone. That
hasn't changed in 20 years. ALK is present, ALK translocation, strictly speaking not a mutation, but another genetic abnormality as opposed to mutation. They're present in about 4 to 8% of patients that we see. I think our experience has been a little bit skewed because we've done investigational studies, first with the original drug. Tracy Evans was your collaborator, was one of the co-investigators on the original crizotinib trials. More recently, we've looked at brigatinib, the Ariad compound, in the second line setting. What's your perspective on these agents? How has that changed practice in this group?
Well, again, I think they've been pretty well tolerated. I'll leave ceritinib to the side of that because ceritinib has certainly some side effects than the other drugs that we've seen. But yeah, I mean, there's so many treatments available right now for the ALK patients. So with the crizotinib being approved, the ceritinib being approved second line, but then there are several agents in clinical trials now that seem to be doing well. And again, really sparing toxicity for these patients. So it's been nice to see.
Crizotinib doesn't seem to have the degree of rash or diarrhea that we typically associate with the standard EGFR TKIs, although we still see side effects, visual changes, although it tends not to be treatment limiting, flashing light scintillations or light-dark accommodation issues that are transient, some peripheral edema, which is, I think, one of the biggest problems I've encountered.
Yeah, I've encountered that a few times.
Yeah. Ceritinib, of course, now is approved for second line, but a lot of GI toxicity. How do you handle that?
I'll tell you, it's interesting because if you look at the NCCN guidelines, they actually list ceritinib as a moderate to highly emetogenic drug, lumped in with your other standard chemotherapies that would fall
like cisplatin.
Sure, like carboplatin and cisplatin would fall into moderately and highly emetogenic. So ceritinib is categorized there as well. So this is something that I think I see it worst in the first couple months of treatment, just like we do with RAS and EGFR inhibitors, and then maybe tends to get better. Certainly dose reductions are in order. You think of seratinib, you're taking 5 pills all at one time. It's easy to dose reduce that and say, okay, just take
to 4 or 3.
Correct, yeah. So I think between using antiemetics and using dose reduction is the way that I tend to manage that, whether it's the nausea or the diarrhea.
So, and the antiemetics sometimes require combinations to actually
Sure,
control it.
and the thing is that really none of the NK1 receptor antagonists are approved for orals, and they're a prevention, not a PRN. So really, if you're looking at PRN use, you're going to use the 5-HT3 receptor antagonist or benzodiazepines, something like that, to control it.
Dr. Mera is one of the major investigators, and she's reviewed the work in ALK inhibition. This was something that was, frankly, not even on our therapeutic radar 6-7 years ago, and it's a transformed practice for a small but real niche of our population. Of course, these patients live longer, so while the incidence is 3, 4, 5, 6, 7, 8%, the prevalence in our practice is double that because fortunately for these individuals, their prognosis is better. More recently, alectinib and brigatinib, as I mentioned earlier, have shown activity in individuals whose disease has progressed on frontline therapy. There is an ongoing phase 3 trial comparing alectinib, which has much less the toxicity that's been seen with ceritinib, but phase 3 comparing alectinib to first-line crizotinib, called the ALEX effort, and then brigatinib is being looked at in randomized phase 2 at 2 different doses, again in individuals whose disease has progressed on crizotinib. I want to finish up with 2 other observations from this conference. We've seen some new studies in malignant pleural mesothelioma, a major study from France that has grafted bevacizumab, already approved in non-small cell, onto the PEM platinum platform and resulted in a similar 2 to 3 month improvement in median survival. Perhaps not standard yet, certainly not yet FDA approved, although that may happen shortly. But median survival now in a treatment-naive mesothelioma patient with that triplet combination is 18 months and greater, which is certainly a lot better than we started out 15, 20 years ago when it was about 8 to 10 months. And there are data, Evan Alley, who presented these data, actually was the principal investigator of the study, looking at new immunotherapy, specifically pembrolizumab, in individuals whose mesothelioma stained positive for PD-L1 with a response rate in the high 20% range. And again, some of these responses were quite durable, and these were heavily pretreated individuals who had had not just 1, but sometimes 2 or 3 other regimens. And finally, in small cell, Dr. Baumel has presented data focusing on some of the new strategies in immunoconjugate that targets the delta protein, which is present in about 2/3 of small cell individuals. This immunoconjugate has resulted in response rates, again, in heavily pretreated individuals, about 50% or higher. So stay tuned. There'll be a lot more research into this drug. It does have a fair amount of toxicity. And again, as we've seen in just about every other disease, immunotherapy, PD-1 inhibitors alone, PD-1 inhibitors in combination with CTLA-4 inhibitors that have resulted in response rates in the 20 to 30% range, including platinum refractory patients. So it's been my pleasure to review the recent data presented at the 20th Annual Perspectives in Thoracic Oncology meeting here in New York City in November 2015. I am joined by Beth Eaby-Sandy. It's been a great pleasure to go back and forth and rap about lung cancer in this setting, and certainly a lot more promise and hope even in the last 2 years than we had seen perhaps in the previous decade. Thank you very much for your attention.